You are participating in Medicaid after the PHE, which is the second, did my slide switch there? There we go. Okay. Which is the second presentation in a series of, I think, 5. So last week, you may have heard from my colleague, Ashley Watson, on telehealth, and I'm speaking today about Medicaid and the unwinding. You can see on the screen also something unrelated to this speaker series, but a save the date for BMD's Healthcare Innovation Summit, which will be held in February of 2024. So next February at Lake Nona Wave Hotel in Orlando, Florida. If you've not participated in our Healthcare Innovation Summit, it's an excellent opportunity to network and learn from BMD clients and friends about really innovative things in the healthcare space. So it's not a bunch of attorneys droning on and on about regulatory matters. It's super interesting. I encourage you to keep your eyes and ears open for that opportunity in the future. Okay, let's move right into it because we have quite a bit of content. So here's our agenda for today. I will tell you a little bit about myself and about BMD if you don't already know. We're going to take a brief trip down COVID memory lane. And then we'll spend the bulk of our conversation talking about both changes to the Medicaid programs and the effects of the unwinding of the public health emergency. And then we'll spend the last half of our conversation talking about the No Surprises Act, which you may already have heard my colleague Ashley Watson and me talking about in separate presentations, because we do a spiel on the No Surprises Act as well. So I'm Daphne Kackloudis. I'm a member at Brennan, Manna, and Diamond. I'm a partner in the healthcare group. I'm geographically located in Columbus, Ohio, but BMD has offices in Ohio and all over the country. BMD is a mid-sized firm with a very diverse range of practice areas, including healthcare. And as you know, we'll be talking about healthcare today and the public health emergency and all things related to it and unwinding. Please don't hesitate to reach out to me directly. If you have relationships with other BMD attorneys, certainly reach out to them. And we can help orient you to this subject matter and others as well. Okay, so here we go. I read an article recently about a research project that used our collective experience of the pandemic to understand memory. It's super interesting. And one of the key takeaways is that from this article is that though the pandemic was literally life-altering, other than for people who experienced the loss of a loved one as a result of the pandemic or members of the healthcare industry, so if you're not one of those people, if you're sort of the majority of other people, we've already begun to lose memory of the ways in which our daily routines actually changed during the pandemic. And I know this is true for me. Sometimes I think back to those, 2.5 years of pandemic, and I can't quite remember what things were like. I certainly can't necessarily appreciate the sort of gravity of the situation like I did in real time. So I thought it would be helpful to look at some of the milestones that sort of set the backdrop for our conversation today. So just take a look at this. This was sort of interesting in putting this together. I'd forgotten about the order of these events and the timing of it. So just remember back to mid to late January of 2020. So 3 years ago, a little over 3 years ago, for many of us in the United States, that's when COVID became real. On January 31st of 2020, both the WHO and HHS Secretary Azar declared COVID a public health emergency. And then nearly a month later, the CDC informed the nation that significant mitigation efforts, including closing schools and places of business, would be disseminated and enforced. And then just a few weeks after that, the states did in fact begin to implement shutdown orders to stem the spread of COVID. So that's sort of the backdrop, right? That all happened between really January and March of 2020, so 3 years ago. In March of 2020, the same month that states began to implement those shutdown procedures in response to the public health emergency declared on January 31st, and anticipating greater need for health services and foreseeing an impact to the workforce and loss of private insurance coverage as a result of the emerging pandemic, many state Medicaid programs, including the Ohio Department of Medicaid, implemented a bunch of operational changes to their Medicaid programs. Examples of some of those operational changes made by ODM and other states include the use of flexibilities offered to the states by the federal government, such as increasing service limits for home and community-based services, expanding telehealth, and also I'll just sort of put an asterisk here while I'm thinking about it, that there was an announcement today about essentially anticipating the end of the public health emergency on May 11th. The federal government is putting providers on notice that those that enforcement of HIPAA sort of as an opportunity to quickly implement telehealth during the pandemic is coming to an end with the end of the public health emergency on May 11th. So when I think of telehealth, and particularly the announcement today, to sort of keep your ears open, that you as healthcare providers will begin to see enforcement actions due to the unwinding of the PHE. So other flexibilities that the states begin to use in addition to increasing service limits for home and community-based services and expanding telehealth, adding healthcare isolation centers as a nursing facility benefit, for example. So at the same time that the states were implementing those flexibilities offered by the federal government at the beginning of the pandemic, Congress passed the Families First Coronavirus Response Act, affectionately referred to as FFCRA, which did a lot of things, including providing states with a 6.2% increased federal medical assistance percentage, or increased FMAP, or sometimes called enhanced FMAP or EFMAP, for Medicaid programs. And in exchange for the enhanced FMAP, states were then required to keep Medicaid enrollees in the program until the end of the month in which the public health emergency ends, which we now know is May 11th. And this change eliminated the need for state Medicaid programs to reevaluate enrollees' eligibility and ensured that people retained coverage during the pandemic. So that was kind of an additional flexibility. Federal government gave states some enhanced FMAP, some additional money, because they knew that the Medicaid program would be growing, and in exchange, the states had to agree to keep people enrolled through the end of the public health emergency. And I just found this interesting. I know you're not, all of you are not in Ohio, but I'm using some Ohio statistics because that's where I'm located. Through the end of calendar year 2023, this calendar year, Ohio will have received a total of about $5.1 billion in enhanced federal matching funds. And federal and state efforts to ensure Medicaid enrollees did not lose coverage during the PHE worked. The Medicaid program actually saw a 30% increase in enrollment. Fast forward, now we're still sort of going down memory lane. Fast forward to December of 2022. So just this past December, I don't know, 4 or 5 months ago. And that was a little more than 2.5 years after the beginning of the PHE. At that time, December of 2022, Congress passed the Consolidated Appropriations Act of 2023, the CAA, which includes a number of provisions related to Medicaid and the Children's Health Insurance Program, or CHIP. Highlights of the CAA that affect Medicaid and CHIP include delinking, we'll spend a lot of time talking about this, the first part of our conversation, delinking the Medicaid continuous coverage requirement from the public health emergency, and starting its unwinding after March 31st of 2023. Also requiring all states to provide 12 months of continuous eligibility for children in both Medicaid and CHIP, extending the federal funding for CHIP for an additional 2 years, making permanent a state option to provide 12 months of postpartum coverage in Medicaid and CHIP, and a couple of other things. So the result of ending continuous Medicaid coverage means that states are resuming routine eligibility operations. Ohio began its normal eligibility operations on February 1st, 2023, so just a little over 2 months ago. And ODM is now requiring all members, all Medicaid beneficiaries, to begin the redetermination process after March 31st, meaning that all people in Ohio, for example, who are eligible for Medicaid will have to renew their Medicaid coverage. And the result, as you can anticipate, is that some Ohio Medicaid beneficiaries will be disenrolled from Medicaid. ODM expected the first round of termination letters to be mailed to those no longer eligible beginning on April 1st. So ODM anticipated or planned to send its first round of termination letters on April 1st, so a couple weeks ago, week and a half ago. And because we'll begin to see an increase in the number of people who lose Medicaid coverage or become uninsured, you and your organization as healthcare providers should make sure you have a thorough understanding of the No Surprises Act, which we'll talk about during the second part of this presentation. Okay, so currently there are 91 million people in the country enrolled in Medicaid. 15 million of those are expected to be terminated as a result of the ending of the continuous coverage provision of the FFCRA. Also, another data point just of interest in Ohio, since February of 2020, so right when the pandemic was in full swing. So since February of 2020 in Ohio, Medicaid's caseload grew by about 760,000 individuals, which is an increase of about 27%. And that's true in many states, something in that sort of ballpark. Nearly 41% of those newly enrolled during that time, so people without prior Medicaid involvement, or children, nearly 41%, and 12% are newborns. ODM estimates that the caseload will peak at 800,000 by May of 2023, so next month. And based on the 12-month plan submitted to CMS, the state estimates that over 18 months, the caseload will be reduced by approximately 220,000 individuals. The fact is that the end of the PHE is welcome news for many of us, right? Many of us are sort of ready to acknowledge the ending of the public health emergency. I'm sure you saw that just yesterday or maybe 2 days ago, President Biden also ended the national emergency. That signals to us a sort of the official return to normal, but it also brings several changes to Medicaid programs. As I said earlier, the CAA officially delinks the continuous coverage requirement from the PHE. It reinstates routine eligibility operations, and it phases out this enhanced FMAP. So the states are going to start to lose money, and there's going to be, there will be ramifications to you as providers and to really, taxpayers as well. And the CAA also added some rules for states to follow as they unwind their COVID-era Medicaid program changes. So first, let's talk a little bit more about continuous coverage. The CAA set the continuous coverage end date on March 31st, 2023, and it directed states to begin routine operations then. This means termination from the Medicaid program for people who are no longer eligible. That began on April 1st, 2023. So beginning on April 1st, states were permitted to resume disenrollment of people who are no longer eligible for Medicaid, but only after the state conducts a fresh and complete renewal, including examining eligibility for all categories of Medicaid. States have 12 months to initiate renewals and an additional 2 months to complete the processing. It's a really tight time frame if you think about it, and think about the volume of people who have been added to the Medicaid caseload. States are allowed to stagger the start of the unwinding process, and the date on which the state plans to begin the unwinding determines a timeline for submitting the state's renewal plan, submitting to the federal government the state's renewal plan, and baseline unwinding data required by CMS, right? So they're going to begin to measure folks who are falling off the program as a result of this process. States were allowed to initiate their first batch of renewals as early as February, or they could do that in March or April. So this slide and the next slide are probably hard for you to read. You can look at it more closely after this presentation. The March 31st, 2023 statutory end date of the continuous enrollment condition means that states could begin their 12-month unwinding period and initiate the first Medicaid renewals that could result in disenrollment as early as February 1st. And disenrollment can be effective as early as April 1st, as in Ohio. So you can see here, this is an example of the unwinding timeline for states with a 60-day renewal process. The next slide is a 90-day renewal process. We won't spend much time there. But on this slide, you can see an example of the unwinding timeline for states with a 60-day renewal process for the beginning of the unwinding in February, which is option A, that top arrow, March, and April. So, the CMS has explained that states should begin renewals in the month before, the month of, or the month after the continuous enrollment condition ends. So, you might be interested in checking out your state's sort of where your state falls here. This is this similar slide that shows the unwinding timeline for states with a 90-day renewal process. But it's important to know when people will begin to fall off your state's Medicaid enrollment, for what it's worth. Okay, so let's talk a little bit about the actual redetermination process. The redetermination process begins with an ex parte review, meaning the state will use quote unquote recent and reliable information at its disposal to determine eligibility, to determine Medicaid eligibility before requesting information from the enrollee. That's actually a requirement of the CAA. The CAA requires that states get updated contact information before redetermination, before reaching out to the enrollees. Each state's quote unquote verification plan lists data sources and compatibility requirements for data match. Some states made PHE related changes to eligibility, which may be ending. So you really should look up your state specifics. One note is that if the attestation, a person's attestation of their eligibility, and the data match are both above or below the income threshold, that information shall be considered reasonably compatible. So if those two things match up and it shows that they're above the income threshold, that will be considered reasonably compatible information to determine that the person will be out of the program. Or if they're at or below the threshold, that's enough evidence to indicate that the person is still in Medicaid. The CAA also requires states to seek updated contact information prior to attempting redetermination. So they have to get this information from their data sources before they reach out to the people. Next, if the ex parte review is unsuccessful, so for example, if the eligibility cannot be renewed through the ex parte process, the state then is required to send a renewal form to the Medicaid beneficiary. The renewal form asks only for information needed to complete the redetermination and gives that person a reasonable amount of time for the individual to respond. It's 30 days for a MAGI. The state is required to enable individuals, Medicaid beneficiaries, to submit the information requested, to submit that information in person, by mail, online, or by telephone. So you can imagine the administrative burden, I guess, on the states to ensure that the state itself can receive information in all these different ways. Many times also by now states have sort of phased out some of these approaches to eligibility determination. So they're kind of going backward and adding them back to their processes. States are required to make a good faith effort to contact the individual about termination by multiple modes before just terminating them because mail was returned to them. So it's a lot of effort required by the state. States are also required, the CAA also requires states to consider Medicaid eligibility for all categories of Medicaid and must seek information regarding other categories if needed to evaluate eligibility. So what this sounds like to me is that if a person is enrolled in a particular Medicaid eligibility category, the state reaches out to that person to, confirm that they're still eligible in that category. And if they're not, then the state is required to do some additional work to make sure that that person is eligible maybe for another eligibility category. And for individuals who are determined ineligible for Medicaid in any of those categories that the state has, the state is also required to assess for insurance affordability and transfer the account to maybe the marketplace or something like that. States are required to have procedures for individuals to report changes in their circumstances, and they may run periodic data checks. So for example, against wage indexes in the state between annual renewals. Importantly, states are not allowed to send advance notice of termination for individuals found ineligible during the PHE. So if during the PHE, the state did a determination, found that the person was ineligible, the state cannot proactively send a notice to that person saying, you're out of the Medicaid program. And that includes individuals who have failed to respond to a request for information sent during the PHE. Individuals generally are required to receive a full renewal, a quote unquote full renewal, prior to any adverse action. And there are a couple of exceptions to the full renewal requirement, for example, a recent change in circumstances, or a couple of other things. Okay, So each state is different, obviously. And each, this is the old adage goes, if you've seen one Medicaid program, you've seen one Medicaid program. So each state is different, but is likely using methods similar to Ohio. In Ohio, the Ohio Department of Medicaid is partnering with state and local agencies, provider organizations, Medicaid managed care plans, consumer advocate groups, all kinds of partners as it ends continuous eligibility. ODM actually implemented several tools to improve and prepare for the process, including enhanced county funding and training, right? Because in Ohio, we're a county-based system, so a lot of this work will fall to the counties. So they actually have enhanced funding for the counties and provide additional training, which is great. Leveraging federal temporary waiver flexibilities. We'll talk a little bit about that in a minute. And improving ex parte renewals and other significant information technology improvements, which is a good idea anyway, because states are required to do eligibility determinations in real life, right, and non-pandemic times anyway. So improving the ex parte process just makes sense. It should sort of expedite these processes going forward. Also using multiple communication methods to reach out to people and inform people of their pending renewals and timelines. Streamlining and improving system operations, which is always a good thing. Prioritizing caseworker responsibilities to individuals found likely to be ineligible. So I think that really leverages the importance of caseworkers and people who are already in contact with folks, particularly those who, maybe because of their income or other circumstance are likely to be found ineligible. The state of Ohio has also created an unwinding partner toolkit for provider and consumer groups to reach out to their members, and has consistent messaging, which of course is really important. And also important, synchronizing SNAP and Medicaid eligibility renewals. And we'll talk a little bit about that more in a minute. So in fact, we'll talk about it now. To support states in their efforts to successfully unwind from the Medicaid continuous coverage requirement and to resume normal eligibility, quote unquote, normal eligibility and enrollment operations, CMS has made available to states several time-limited 1902 E14 waiver authorities. Section 1902 E14A of the Social Security Act allows for waivers, quote unquote, as are necessary to ensure that states establish income and eligibility determination systems that protect beneficiaries. So CMS last used that authority, excuse me, this 1902 E14 authority when states were transitioning their eligibility and enrollment systems to be compliant with the Affordable Care Act. In the context of the COVID pandemic, CMS has is sort of using the same authority to extend this temporary authority to states to, quote unquote, promote enrollment and retention of eligible individuals by easing the administrative burden states may experience in light of systems limitations and challenges. So essentially, the federal government is allowing states some additional flexibility to protect beneficiaries during this uncoupling of continuous coverage and the PHE. So the 1902 E14 strategies related to unwinding that are newly available to Medicaid agencies can provide relief to those states facing overwhelming and voluminous eligibility and enrollment actions and processing delays. Also workforce and systems limitations, as you can imagine. I mean, we're already in a workforce crisis, so states have had to sort of staff up to do this. Ensuring that eligible individuals do not lose coverage as a result of procedural or administrative reasons, and supporting those who are ineligible by transitioning them from Medicaid to the marketplace coverage is of paramount importance for all the states as they begin to assume normal operations. So these 1902 E14 waiver strategies include enroll folks in Medicaid or keep them enrolled in Medicaid based on SNAP and or TANF eligibility, using ex parte efforts for people with no income and no data returned, partnering with the Medicaid managed care plans to update beneficiary contact information, using the National Change of Address database, which I think is genius, to get some of that information, extending automatic enrollment into Medicaid managed care up to 120 days, extending the time frame to take final administrative action on a fair hearing, and delaying resumption of premium. So the federal government is making available to states some of these tools to ease the burden as a result of the ending of continuous coverage. Okay, speaking of flexibilities, on January 30th, 2023, the Biden administration announced its intent to end the PHE on May 11th. Those emergency declarations have been in place since early 2020, and they gave the federal government flexibility to waive or modify certain requirements in a range of areas, including Medicare, Medicaid, CHIP, which of course we care about today, and also allowed the authorization of medical countermeasures and to provide liability immunity to providers, right? So these announcements made not that long ago, essentially will change the way that we've been doing Medicaid business for the last couple of years. So you'll recall that as a result of the PHE, the federal government's provided additional flexibilities tied to some of these emergency declarations. This chart is hard to read. You can look at it more closely after this presentation, but I'll sort of walk you through it. So what we're looking at here are the federal flexibilities that have been provided to states that states are using and when those will expire. So disaster relief state plan amendments that allow HHS to approve state requests to make temporary changes during the COVID emergency to address eligibility, enrollment, premium and cost sharing benefits. Those are state plan amendments. Those will expire at the end of the PHE or an earlier date selected by the state. COVID-19 Section 1115 demonstration waivers. Those will terminate 60 days after the PHE ends or on an earlier date approved by CMS. And Section 1135 waivers will terminate no later than the end of the PHE. And then finally, and I know a lot of states are using these Appendix K waivers that allow the federal government to approve state requests to amend their 1915C or 1115 waivers, HCBS waivers to respond to an emergency. Those waivers will expire no later than 6 months after the PHE ends. These are the flexibilities that the Ohio Department of Medicaid has elected to use, and these will be ending. And you can see here, there's a good amount of them. These flexibilities will be ending on one of those dates that I shared with you. Okay, so the CAA did a lot of things, as we talked about, also gives states additional financial support during the unwinding period. While the enhanced FMAP that we talked about, that additional 6.2%, under the 2020 FFCRA included a full sunset of enhanced funding at the end of the quarter in which the PHE ends. The CAA, so that legislation that was passed just in December, instead gradually phases out the enhanced FMAP through 2023. It'd be pretty devastating to states if they, all of a sudden lost that 6.2% in one fell swoop. And then additional funding, during this unwinding will support states as they work through those large number of eligibility reviews. To continue to receive the enhanced match through the phase out period, through this unwinding period, states must follow federal eligibility requirements, maintain updated enrollee contact information, and make good faith efforts to contact enrollees before their coverage is terminated due to return mail. So essentially, in order to continue to get the enhanced FMAP, the state is required to do all those things we already talked about, ex parte, ensuring that people are enrolled in, if eligible, any Medicaid category, and so on and so forth. You can see here the phase out period. So the enhanced FMAP will begin to unwind over the next couple of years. States receive that 6.2% enhanced FMAP, and they'll continue to get that during the first quarter of 2023, and then will gradually decrease throughout 2023, as you can see here. So the grace period is not that long, but it is helpful for the states to begin to, sort of phase that out. Okay, so now we're going to go back just a minute to talk about the unwinding of continuous coverage and specifically some of the problems expected as a result. And this will launch us into the second part of our conversation on the No Surprises Act. So some, anticipated problems with the elimination of continuous coverage. First is the failure to renew via ex parte. I mean, I think the states are anticipating that the ex parte renewal process will be successful for a lot of folks who are easily reachable and, aren't terribly challenged by, things like housing instability. But there will be a significant number of failure to renew as a result of the ex parte process. Another challenge for states is the sheer number of enrollees. That means overwhelmed eligibility systems, overwhelmed workers. These systems also contain untested changes and newer automation, things that haven't been tested before, used before. And there are new workers in understaffed departments. So, I think sort of the sheer administrative or workforce burden is very real for states. Also long wait times at help centers and on helplines, as you know. In fact, just before I hopped on this call, I was trying to reorder a water filter for my refrigerator. I was actually working with someone. It should have been a 2-minute process. It was a 10-minute process. I had to hop on this webinar, so I hung up, right? So think about these overwhelmed helplines that folks will have to sit on the phone for probably, hours in order to process their eligibility. A lot of people who have moved since March of 2020, right? I mean, think of all the people in your life that who have had some major life event related to or unrelated to the pandemic, including moving. So, new job, loss of job, new family members, loss of family members, all these things impact Medicaid eligibility. And then, of course, accessibility and language access. And lastly, because many current Medicaid enrollees will lose their coverage and become uninsured or self-pay, the number of people to whom the good faith estimate requirement of the No Surprises Act applies will increase. And that means more work for you. And that's what we're talking about next, after I get a drink of water. Okay, so as you probably know, the No Surprises Act is a federal consumer protection law that helps control the practice known as surprise billing for medical care. The act was signed into law on December 27th of 2020 as part of the Consolidated Appropriations Act of 2021, not to be confused with the CAA of 2022 that we've been talking about. It's a different CAA. Most sections of the legislation became effective on January 1st of 2022, so they've been in effect for about a year. There are 3 parts, really, technically, of the No Surprises Act. We talk mostly about Part 1 and Part 2, but then there's also this air ambulance rule that comes between Part 1 and Part 2. Part 1, the regulation, Part 1, establishes new protections from surprise billing and excessive cost sharing for consumers for emergency services and certain non-emergency inpatient services. We're not really talking much about Part 1 today. The air ambulance rule requires collection of data on the air ambulance provider industry. We're not talking about this rule at all. And Part 2 is where we'll focus. Part 2 requires healthcare providers and facilities to provide a good faith estimate of charges to uninsured and or self-pay individuals. It also includes details of the federal arbitration process and the independent dispute resolution process that providers, facilities, or providers of air ambulance services and health insurance plans will use to determine the final payment between those two. So Part 1, the air ambulance rule, which I guess is like 1.5, and Part 2. Okay, Part 1 in brief, really, we're not spending much time on this at all. The Part 1 regulation applies to a more limited set of providers and services than does Part 2. It's not uncommon for providers to conflate components of Part 1 and Part 2, so I just really want to be clear about the scope. This rule, this Part 1, applies only to surprise medical bills for emergency services provided in an emergency department and non-emergency services provided by out-of-network providers at in-network hospitals, outpatient hospital departments, critical access hospitals, and ASCs. Part 1 protects people from surprise medical bills for emergency services essentially provided in one of those settings. Under the rule, if a health insurance plan covers any benefits for emergency services, it must also cover out-of-network emergency services and is required to do that without prior authorization. We're not focusing on Part 1 today. That's literally all I'm going to say about it, but I want you to know that it exists, and this is not what we're talking about today. What we're talking about today is part two, a part of part two, actually. Part two does a lot of things, but today we're focused on the good faith estimate requirement. Under part two, providers must give to uninsured or self-pay individuals a good faith estimate of the cost of items and services. Please note, this rule has much wider applicability than part one. It applies to the vast majority of healthcare providers, even if part one does not. FAQs from CMS state that there are no specific facility or provider types exempt from part two, right? So if you're a healthcare provider, it applies to you. Dentist, it applies. FQHC, it applies. A healthcare facility is defined as, quote, an institution such as a hospital outpatient department, critical access hospital, ambulatory surgical center, rural health center, FQHC, laboratory, or imaging center. And a healthcare provider, scrolling down, a healthcare provider, quote unquote, healthcare provider is a physician or other healthcare provider who is acting within the scope of practice of that provider's license or certification under applicable state law, including a provider of air ambulance services. So healthcare provider means if you are licensed by your state as a healthcare provider, you're a healthcare provider for purposes of part two and the good faith estimate requirement. Okay, so the NSA requires providers and facilities to make a good faith estimate of the expected charge for items and services scheduled. Items or services has the same meaning given the term in 45 CFR 147.210A2, which includes all encounters, procedures, medical tests, supplies, prescription drugs, DME, and fees, including facility fees, provided or assessed in connection with the provision of healthcare. The definition of items or services encompasses and accurately defines the types of items or services that are expected to be reported in the good faith estimate, including items or services such as those related to dental health, vision, substance use disorder, and mental health. HHS also clarifies that some items or services may not be included in the good faith estimate because they're not typically scheduled in advance, like emergency services, and are not typically the subject of a requested good faith estimate, such as urgent, emergent trauma, or emergency items or services. However, HHS clarified that to the extent an urgent care appointment is scheduled at least 3 days in advance, these interim final rules do require a provider or facility to provide a good faith estimate. So this is common sense, right? How can you provide a good faith estimate 3 days in advance of the service if the service is unanticipated, is an emergency service? But if you're using your urgent care, kind of as a pseudo primary care provider and you schedule that appointment, then that service, though provided in an urgent care, might be a service that's subject to the good faith estimate requirement. A good faith estimate is a notification of an expected charge for a scheduled or requested item or service. In general, the good faith estimate should reflect the amount the provider or facility expects to charge for the item or service provided. It should include items or services reasonably expected to be provided in connection with a scheduled or requested item or service. And it should be provided in clear and understandable language. Take a drink. Good faith estimates must be provided to uninsured or self-pay patients. To determine if an individual is an uninsured or self-pay individual, the provider or facility is required to ask if the individual is enrolled in a group health plan, a group or individual health insurance coverage offered by a health insurance issuer, a federal health care program, or a health benefits plan under a federal employees health benefits program. Note that enrollees in federal healthcare programs are not eligible to receive a good faith estimate, or they're not required to be the recipient of a good faith estimate, as there are other surprise billing protections for those programs. But I think the takeaway here is you're required to ask a patient is if they are insured. And even if they are insured, if they do not want the claim to be submitted to their insurance company for that particular service, then they are considered self-pay. The good faith estimate should include the following items: the total expected charge for providing the scheduled item or service, the expected ancillary items or services reasonably expected to be provided With the scheduled item or service, any items or services reasonably expected to be provided by another provider or facility, and the expected billing and diagnostic codes. So here's an example. For a cochlear implant surgery, the good faith estimate might include the cost of the estimate itself might include the cost of the surgery, any labs or tests that are scheduled at the same time as the surgery, and the anesthesia that might be used during the surgery. If an item or service is something that is not scheduled separately from the surgery itself, it will generally be included in the good faith estimate. So like I said, if the person calls into the surgery center and they're scheduling and they schedule the surgery and some pre-op and post-op and anesthesia, that's all included in the good faith estimate. This might include diagnostics done during the same day as the surgery or anesthesia, as I said. Other items or services related to the surgery that might be scheduled separately, like maybe PT or something following the surgery, are not necessarily included in the good faith estimate. If any provider or co-provider that is issuing a good faith estimate anticipates or is notified of any changes to the scope of a previously furnished good faith estimate. So for example, anticipated changes to the to expected charges, items or services, frequency, right? So if the estimate includes 6 sessions of PT, but the provider anticipates or then has some reason to know that that's really extended to 12 sessions of PT, then that provider must provide the individual with a new good faith estimate no later than 1 business day before the items or services are scheduled to be furnished. If any changes in expected providers or facilities represented in the good faith estimate occur less than 1 business day before the item or service is scheduled to be furnished, the replacement provider facility must accept as its good faith estimate that of the replaced provider facility. So like, I don't know if this is even realistic, but let's say the surgeon who's anticipated to provide the service gets sick and you have to use another surgeon. The replacement provider must accept as its good faith estimate that of the original good faith estimate. Good faith estimates are not required to include changes for unforeseen items or services that are not reasonably expected and that occur, outside of those foreseen or scheduled events, which makes sense. It's kind of back to the original thing. How can you include in an estimate something you didn't anticipate happening or existing? The good faith estimate provided by the convening provider, we'll talk about that in a minute, or the provider or the facility, to an uninsured or self-pay individual should include the following. So these are the things that the good faith estimate should include: patient's name and date of birth, description of the primary item or service in clear and understandable language, and if applicable, the date the primary item or service is scheduled, an itemized list of items or services grouped by each provider or facility reasonably expected to be furnished for the primary item or service, and items or services reasonably expected to be furnished in conjunction with the primary item or service for that period of care, including items or services reasonably expected to be furnished by the convening provider or convening facility for the period of care, and items or services reasonably expected to be furnished by co-providers or co-facilities, which we'll talk about in a minute. The good faith estimate also must include the applicable diagnostic codes, expected service codes, and expected charges associated with each listed item or service. The good faith estimate must contain the name, the NPI, and the tax ID number of each provider or facility represented in the good faith estimate, and the states and offices or facility locations where the items or services are expected to be furnished by that provider or facility. A list of items or services that the convening provider or facility anticipates will require separate scheduling and is expected to occur before or after the expected period of care for the primary item or service. And the good faith estimate must include a disclaimer directly above this list of items that includes the following information: that separate good faith estimates will be issued to an uninsured or self-pay individual upon scheduling or upon request of the listed items or services. notification for items or services included in this list, which is listed on the GFE. Information such as diagnosis codes, service codes, expected charges, and provider or facility identifiers do not need to be included, as that information will be provided in separate good faith estimates upon scheduling, and including instructions for how an uninsured or self-pay individual can obtain good faith estimates for such items or services. And then a bunch of other disclaimers that I won't spend time talking about. If you're interested, I'd be happy to share those with you. Okay, so here are the time frames for good faith estimates. For items or services scheduled at least 10 days in advance of the appointment, the good faith estimate must be provided within 3 days after scheduling. For items or services scheduled at least 3 days in advance of the appointment, the good faith estimate must be provided within 1 business day after scheduling, right? So this time frame is getting shorter. And if an individual requests a good faith estimate at all, if an individual requests it, it must be provided within 3 days following the request. Importantly, providers shall consider any discussion or inquiry regarding the potential cost of items or services as a request for a good faith estimate. This is true even if the uninsured or self-pay individual uses different terminology, right? It doesn't specifically say, I request a good faith estimate. If they're like, hey, I'm really interested to know how much you think this is going to cost me. That is considered a request for a good faith estimate, and you as a provider must then provide it within that time frame. A provider or facility may issue a single good faith estimate for recurring primary items or services if the following requirements are met. The good faith estimate for recurring items or services must include, in a clear and understandable manner, the expected scope of the recurring primary item or service, such as timeframes, frequency, and the total number of recurring items or services. And the scope of a good faith estimate for recurring primary items or services must not exceed 12 months. So if it's a recurring, series of services within 12 months, you can provide 1 good faith estimate for that. If additional recurrences of furnishing such items or services are expected beyond 12 months, a provider must provide an uninsured or self-pay individual with a new good faith estimate, and communicate that to the patient. Okay, so there are 2 terms that we should talk a little bit about: a convening provider and a co-provider. The convening provider is the provider or facility who schedules an item or service or who receives the initial request, right? So that's like the primary provider. Think of it that way. A co-provider is a provider or facility other than the convening provider or facility that furnishes items or services that are customarily provided in conjunction with a primary item or service. Beginning this past January, so January 23, the convening provider is responsible for contacting all applicable co-providers to collect expected charges for items or services to be provided in the good faith estimate by the co-provider. This applies to items and services scheduled at the same time as the primary items or service. Convening providers must contact all co-providers within 1 business day after scheduling or receiving a good faith estimate request. And then the co-providers in turn must return the good faith estimate for their portion of it within 1 business day of their request, must provide that back to the convening provider. A co-provider must act as a convening provider if the patient asks the co-provider for a good faith estimate directly. Okay. A good faith estimate must be provided in writing, either on paper or electronically, pursuant to the uninsured or self-pay patient's requested method of delivery and within the timeframes that we described earlier. Good faith estimates provided electronically must be provided in a manner that the uninsured or self-pay individual can both save and print. And a good faith estimate must be provided and written using clear and understandable language and in a manner calculated to be understood by the average uninsured or self-pay individual. To the extent that a person requests a good faith estimate in a method other than paper or electronic, the provider may verbally communicate to the person the information contained in the good faith estimate, but the provider should follow up in writing. Sort of the bottom line. It's not enough to just sort of verbally give a good faith estimate and not follow up in writing. I think those are the nuts and bolts of the good faith estimate requirement of Part 2 of the No Surprises Act that will begin to apply to more people because more people will become uninsured as a result of the ending of the continuous eligibility requirement that has historically been linked to the public health emergency. So sort of in conclusion, the PHE is ending on May 11th. States have the option, or have had the option, to begin that disenrollment already. Ohio is one. So people in Ohio and other states have begun to get kicked off Medicaid. So you may already be seeing an uptick in your Medicaid payer mix. And if that's the case, and you're also seeing an uptick in uninsured people as a result of the ending of the continuous eligibility requirement, right? So your uninsured population is growing, then the population to whom you are required to provide information included in the good faith estimate is growing. And that means more work for you. So if you haven't been paying attention to the No Surprises Act yet, this is first of all a reminder that it's alive and well and you should be paying attention to it. And if the volume of uninsured or self-pay patients is growing as a result of the ending of the PHE, then this is a good reminder for you to sort of dust off your policies and procedures and pay attention to the No Surprises Act. Sarah, do we have any questions?
We have one long kind of question and comment. It might be easier to follow up with this one following
Sure.
the webinar. And then we had a couple questions about attendees who wanted to know if we were going to send the slides, which we will following the presentation. So I just wanted to confirm that as well.
Okay, great. So Sarah, you have the name and contact information of the person who asked the long question?
I do.
Okay, great. Any other questions? I can't see the Q&A, so.
No other questions as of yet.
Great. Okay. I'm happy to, stay on for the next few minutes. Folks can drop off if they're moving on to their next meeting, but I can stay on to answer questions if that, is a thing, or we can simply end the Q&A as well. Thank you for joining.